Hey everyone, welcome back to Innate Healthcare Institute's channel. I'm Dr. Whitney, the founder and medical director. And in this series, we're going to start going over some anatomical descriptions of why your low back pain may not work, why your shoulder pain may not be getting better, why your knee pain may not be getting better, and why regenerative medicine may or may not be a solution for you. So in this video, we're going to do low back pain. Or what's typically diagnosed as low back pain. As you'll see, as we'll go over some other areas in the low back that may not have to do with the low back specifically, and I mean like the lumbar spine, which tends to get a lot of attention, but there's so many other areas back there that get ignored. And from the hundreds and hundreds of back injections I've done over the years, I learned some tips and tricks, and I want to share those with you. So let's dive right into it. Here you can see on the screen is my model. We are, for reference, we're looking at, a back. Up here is towards the head. Down here we got a butt. So we're gonna zoom in and we're gonna peel away all these muscular levels. Actually, let me just keep it right there and start to take away some of the connective tissue. There's some muscles going back. So, actually, right away, you can see all the muscular attachments that we have around this low back area already coming in. We have a lot of the glute attachments. We have a lot of the back muscles, huge, big back muscles. And as we peel away these layers, you see there's lots of smaller muscle groups. All of these, every single one of these little attachments that you're seeing could be indicators for why you are having the pain you're having. It's probably might not even have nothing to do with your spine. And again, after doing this so many times with people, you hear this kind of the same story over and over and over. I got my steroid injection and my L3, L4, it did nothing. They gave me a steroid injection. They said I had a herniated disc. It did nothing. Or, the pain gets a little better, but I'm still having pain over here. It's right here. You get down, you press on it, and they're like, oh my gosh. So all of these could be really trouble areas. So let's keep peeling back all these layers. Now look at these attachments up here. When somebody says, oh, it's in the middle of my back and it really hurts. All these tendon attachments. Let's go another layer. Looks like the nerves are on. Let's get rid of some of the connective tissues making everything. So this is just a big block of fascia that it's showing, all this fascial tissue. So let's just get rid of it. It just takes up a lot of the screen. So, okay, so now we're getting a little more down. Whoa, too big of a zoom. We're getting a little bit down to the nitty gritty. And again, it can be so overwhelming, all these ligament and tendon attachments. This is still a muscle group. This is a longissimus muscle that goes up the length of your spine. And look at all these little tiny attachments. Look, it's where it's attaching to your facet joints. Here's some more ligaments. Ligaments are gonna be green. So let's keep going down another layer. So there we got more culprits. Basically what we're doing is we're playing a detective. We get to play a little game of detective when it comes to reviewing your MRI. X-rays I've never found to be super helpful. But sometimes they can rule out or point to some very obvious things. But we're trying to find the culprit or culprits. Culprits is very important. A lot of doctor detectives get caught up on one thing. You find one MRI finding, it's like, I solved the case. I got it. It's this, I see a little herniated disc here. This is the source of your pain. And boy, have I heard them stories. I've heard people say, they did the steroid injections, but I kept telling them my pain's way over here. You can't see where I'm grabbing. My pain's it's over here. It's on the top of my butt. Let me add it. Let me see if I can go back because this is a big one. This is what I inject a lot on people with low back pain. That is they're like saving grace, man. I've done a lot of these people, and this is where I get labeled as like their hero. And all I did was end up, branching out a little bit and picking something besides the spine over here, and this long lumborum muscle where it attaches to the pelvis here. And if you, as a physician watching this, if you can kind of just walk the pelvis, the ilium, and inject on top of this, you don't need imaging. You don't need imaging for this. You can palpate and do this just fine. I did it for years. And inject right here. Oh my gosh, some people you will be their hero. So another one with people when you're kind of holding your hand out here on the side of on the top of your butt, and you're doing this, and this is where it hurts. That might be why. We'll also show another layer we can get down into. So let's just, again, lots of muscles. Here's this multifidus, all these little attachments along the spine. So we're seeing so many culprits of who it could be. Now I might layer. Let's get the connective tissue. Well, let's peel back all this connective tissue. So just reviews real quick. So now here we are. We have your SI joint. So this is kind of coming to the top of your butt, essentially. To be very, let's get graphic. Like this is probably the top of your butt crack right here, for reference. Because this is very important because, again, I've seen so many people that the pain management docs doing what he's doing what he's doing. And the trouble a lot of times is like they get paid by the insurance company, so sometimes they're very limited in what they can do, and so they're going to inject on L4 or something, and they'll get in on this little facet joint, and it's like here patient, it did nothing. It absolutely did nothing, which I always hate to hear. So that's way up there. This is the top of your butt crack. So when somebody holds down that far, you're probably looking at a lot more SI involvement. Go back to this layer. So look at here again, all these ligament. If you get ligament strains, or if this has ligament laxity, it doesn't have to be a big sports injury to strain these tendons and ligaments. It can be sitting too much, just over time, not strengthening them. And they kind of lose their connections, and they get these little micro tears, right? Like it's almost like these are like little tendinous rubber bands, and they start to break, they start to tear on a micro level. A lot of times it's something an MRI won't even pick up. And so let's jump into, we're looking at all these culprits, right? Here's another one. I'll do better than that. Wish I could separate these. So this is the surface of your sacrum and where it attaches to your pelvis, and we'll call this the SI joint. So look how deep down in that is, and look how very minimal that surface area is. And so if you have a lot of arthritis or something down in there, and you're injecting steroids or even PRP or stem cells, and you're just focusing on these facet joints, man, it's probably not gonna do it. You've got to get down in there and inject, or on this PSIS, where there's a lot of attachments as well. So let's go up a little bit. You can see all the nerves coming out. See if I can turn. So here we see all these little facet joints. Great places for stem cell injections. Great, a lot of wear and tear. You'll get this stuff wearing down over time. And let's point these out too. Here we have all these little, what do we call these? Intra-laborum muscles. These are your transverse laborum muscles. So these attaching to each one of these transverse processes. And this, again, so many. That's why I'm such an advocate when we do regenerative medicine and you talk to places and they're like, we'll give you 2 cc's. And these mostly the marketing places. These are places that run by marketers, not by doctors. We'll give you 2 cc's. Great. What does that mean? What's the dose? How many stem cells are in 2 cc's? If there are even live stem cells in there. So that's why we go by we're more of a dose dependent. We're going to use 50 million stem cells, 100, 200, 300 million. How many stem cells in? And then you can take that, you can put that almost in any volume you want. When you get something like 200-300 million stem cells, it gets really thick. It gets really hard to break up all those cells and put them in like 1 cc or 1 milliliter of fluid. And so we're doing injections a lot of times with people with their back. They're like, how many injections are you going to do? Are they like 1 or 2? No, it's probably like 10 or 12, because we have to spread that material over all these different surface areas that we think are going wrong. And usually it's all of them. They're all guilty. All of these joints down here, L5. So it's for reference, this is L5 or sacrum, L4, L3. So you have to make sure you have enough solution to go around and target all these different things. So I get really frustrated when I can get really frustrated when a patient might be coming in, or you hear somebody say, yeah, it didn't work for me. Stem cells don't work. It didn't work for me, because they went to a place that put 1 cc on their L4, L5, which was probably probably could have been the problem area, but they didn't target all of this other stuff they could have injected. And so if somebody does have a herniated disc and that nerve, that it's compressing on the nerve right here. And that's it. I've done that. I found the sweet spot, and that was their problem. And I injected you inject the cells on there, and boom, a month or 2 or whatever, and they're walking better, and they're running, and they're back exercising, and they don't have pain every day. But usually there's a lot of different stuff going on. So actually, while we're on this topic of the discs, let's go back in here. And I wish I could show Paul's disc. It's not muscular. It's not have more connective tissue, which again, there's more stuff that needs to get injected. But let's put a little bulging disc coming out of here, herniated disc. It's compressing on the nerve right there. So let's go up once. What's a little prettier? So the disc is bulging out. Imagine this disc bulging out, it's pressing on the nerve. There's a huge debate, I guess I'll say, as to a lot of people wanting stem cells injected into this disc. And that being the only way. The interdiscal discography injections are waning. They cause more problems usually. There's other solutions or safer solutions for them, but a lot of people are they're diehard, they're set. I want the injection injected into the disc. It's tough, it's fibrous, it doesn't have a lot of room to put fluid. And like I said, if you can have more volume, you can have a more amount of cells in there. And if you can only get like 1 cc in there, are you even doing enough to solve the problem? Will it work for some people? Yeah, it'll work. You'll find people that say, yeah, I got it. My intradiscal injection ended up getting better. So the argument is not if it could, but what's a better approach? So to give, no, I want to go this way. So if I could show like this, so a lot of people get really curious as to what we do. What we do, like literally like what we do, like what's going on with the injection, like what I need to know what you're going to do. And I really encourage you, just get out of that anxiety mindset. Let the professionals do it. I get it. I'm a little guilty of it myself, but when the needle is coming in this way and you're injecting the solution, maybe your target on the C-arm on the fluoroscopy is to kind of hit, where am I at? And for reference, this L4 joint, you want to have enough solution that it kind of bathes over the nerve here and spreads out to a herniated disc. Or what we'll do is you can take this angle, when we have a C-arm, it's like a guided x-ray. And so when you're guiding the needle in, you want to get it kind of close to the herniation without kind of aggravating it and stabbing it and poking it even more. And you could do that and it works just fine. So, when you're doing that for your patients and you're a little worried, and maybe if you don't have that good of imaging, a lot of times just targeting the facet joint and making sure you have, 3, 4, 5 cc's you can put around this area, so you can make sure it gets the disc herniation, will work great. So this is kind of like what we would see from a C-arm, from a fluoroscopy. I prefer C-arm doing the back. I don't like ultrasound as much. C-arm is much better for me. So this would be kind of like what we see. It's like an x-ray, and we're gonna look at the structures, and we're gonna, it helps us determine, along with anatomy, where to guide the needle. It does make things a lot easier. I'm a big anatomical injector. I'm a big intuition kind of guy. I'll have people come in, I have my low back pain, and I'll press right there, and they go, "Oh my God, that's right where it's at." Yeah, I kind of knew that. You'll see a big mix. You'll see a lot of people that only use imaging. They won't inject without it, and you'll see guys who usually been doing it all for a while, and they'll say, I know my anatomy. I know that if I come here to the spinous process at the top of their ilium, I'll palpate for that. I'll come in, I'll press this spinous process, this little pointy part right here, which you can normally feel. If you feel your spine, that's what you're feeling, or those sticking up. I'll grab this, and now I know if I come out, about a thumb, 2 thumbs width, I'm right around the facet joint, and I can reach down there and get my needle contact, and I can feel it. So, yeah, there's a good overall. Hopefully, it helps you out, kind of figure out like, man, why isn't my back pain getting any better? I've gotten steroid injections, and it's not getting any better. Well, it's because there's a lot of culprits going on back here, and when we target stem cell medicine, you got to kind of be precise, whether you're using imaging or not. You still need to know, who to inject on, the culprits. Going back to our detective analogy, where do I inject it? Am I injecting here, SI joints, here, the PSIS? I'm going to hit 5, 4, 3 on their facet joints. There's some disc bulge, so I'm going to make sure I get a little deep down behind here and get that. There's some pain out here on the ilium. So you can have a ton of injections, and a lot of times I hear, unfortunately, I get to hear all the failure stories. I went down to Mexico and I got an injection and it didn't work. Why would I come to you? Like, what are you going to do different? What do you mean you got an injection? Well, I went down for my back pain and they gave me an injection. You're saying an injection. Do you really mean one injection? Yes, I went down and I got one injection. This is true stories, and it's not something I've heard once. I went and got one injection in my back. And these people have 2, 3 herniated discs, multiple facet arthropathy throughout their spine. Probably things the MRI didn't even pick up. So they have really bad pain, and somebody just went and stuck a needle, I don't know, right here. I did have one lady actually point to her butt, like she was getting an intramuscular injection. And I said, "Are you sure that you just got one injection right over here?" And she said, "Yeah, I did." Man, that was a complete, not a waste. I won't say it's a waste. If she got decent stem cells, an intramuscular injection is still good. But is it what she needed or No, not at all. So I hope you like that. I hope that was a bit informative. Let me think real quick on what else, anything else. Here you see, these are the nerves branching out, by the way. So you got these ones coming out of the sacrum. Here they join down to create your sciatic nerve. Let's back out, down. So, these create your sciatic nerve, and then these branch up through these lower lumbars. But yeah, I hope you liked that. I hope you enjoyed it. Click like, please, if you did. Subscribe to the channel if you want to see more in general content on just stem cell medicine, being healthy, staying healthy, and comment on what other areas you want to focus on. I plan to do every joint. So I'm going to do a video on hip. On the major ones at least. Not every joint. I'm not doing every joint. Hip. Let's do shoulder. We're going to do knee. We can do ankle. So all the big ones that we inject. We'll do neck. We can come up here and do the thoracic a little bit, but we'll do a video on cervical. So subscribe so you can get alerts and notifications to when we have the next video out. But yeah, comment on which one you'd like to see. Maybe it's something that not super common, like scapular pain, where I've injected along the border of the scapula, where there's a bunch of these muscle attachments that ended up being the trick, doing just fine for a patient. So thank you so much for tuning in, and we'll see you in the next video.